Hello, Dr. Raymer here, and today we're talking about blood flow to the brain and vascular accidents. So here's the learning outcomes for the talk. We'll talk about the vascular territory of the major cerebral arteries, on to mechanisms of stroke, including the common terminology for different types of stroke, and most importantly for our purposes, we'll use functional anatomy to predict the deficits associated with vascular accidents at different locations. So let's start with the vascular territory. Now, the blood supply to the brain arises from two major sources, the vertebral arteries and the common carotid arteries. The vertebral arteries give rise to the posterior circulation, while the common carotids, and ultimately internal carotids, give rise to the anterior circulation. And here, in this diagram on the left, in lateral view, you can see the left vertebral artery arising from the subclavian artery and traveling through cervical foramina to arrive at the brain. And the anterior circulation is shown in this sort of frontal view. And in terms of the anterior circulation, the internal carotids arise bilaterally from the bifurcation of the common carotids, and that's where they enter the brain. Now, while we have two divisions of circulation, anterior and posterior, the blood flow to the brain isn't divided symmetrically between the two. So by most estimates, the internal carotids together give rise to about 80% of blood flow to the brain, while the vertebrals, which merge to form the basilar artery, as you can see here are the vertebral arteries in this view. Here's the big basilar artery. And then it gives rise to all kinds of branches. And those contribute, by most estimates, about 20% of blood flow to the brain. However, the vertebral arteries crucially supply the brainstem. And so they might not give rise to a lot of the volume of circulation, but they supply crucial structures that are required for our survival. Now, the white dashed line on this slide gives us a depiction of the dogmatic circle of Willis, the arterial link between the anterior and posterior circulation. Now, although we see it almost always depicted in this perfect arterial polygon, the circle of Willis is actually incomplete or abnormal in about 75% of us. Here are the vessels that make up that dogmatic circle of Willis. So on the anterior side of things, we have the left and right internal carotid arteries, the proximal or horizontal, so-called A1 segment of the anterior cerebral arteries, and the anterior communicating artery here. On the posterior side of things, we have the left and right posterior communicating arteries, the proximal segment of the posterior cerebral artery, PCAs, and the tip of the basilar artery. So those vessels do make up the circle of Willis. However, it's really important to know that one or more of those vessels might be hypoplasic, i.e. smaller than normal, or missing entirely in many of us. And even in an intact circle of Willis, it certainly does not confer complete redundancy of blood flow to the brain. Now, the internal carotid artery arises bilaterally from the common carotid artery, and it enters the skull here via the carotid canal. This is a posterior view cutaway. You can see the artery traveling through the petrous portion of the temporal bone and ascending to split into the MCA, which goes laterally, and the ACA traveling medially. Now, before we go on, I just want to point out two other arteries that are important clinically. So the anterior choroidal artery arises directly from the internal carotid as a little branch, and it supplies the ipsilateral optic chiasm and optic tract, as well as some deep brain structures. The ophthalmic artery here is another little branch of the internal carotid, and it enters the orbit and supplies the ipsilateral retina. So just two little branches you should be aware of. Now, as we've already seen, after they enter the brain, the ACA and the MCA take different courses. So this slide shows the ACA traveling medially over the surface of the brain, and I'll trace two of its major branches. As an aside, I know we're talking about anterior circulation at the moment, but the PCA sort of supplies the remainder of medial cortex. In contrast, the MCA travels laterally over the surface of both hemispheres, its hemisphere. And you can see there's two major divisions. After it exits the lateral sulcus, the MCA has a superior division, superior to the lateral sulcus, and inferior division, inferior to the lateral sulcus. But this slide looks confusing because there's all this stuff going on that you actually can't see from the outer surface of the brain. Now, just to orient you in this coronal schematic, here is the internal carotid, taking a zigzaggy route to get to the brain. Here's the bifurcation point, and here's the medial ACA and the lateral MCA, traveling that way. Arising mostly from the MCA at its proximal point, near its proximal point, but also less so from the ACA, here's one, are these little branches that are called perforating branches or lenticulostriate arteries. And they perforate to enter deep, to supply deep brain structures. You might guess from the name, the lenticular nucleus and the striatum, for example. As we continue along, we can see two things about the MCA. First, we see these branches that are filling the operculum, and we'll show you those in a second. And next, distal to that point, we see it split and spread into two divisions above and below the lateral sulcus, some called the superior division and the inferior division of branches of the MCA. Now, in this dissected brain, we can see all the little branches of the MCA that are revealed when we remove the operculum, those bits of cortex that cover the lateral sulcus. So when we remove those opercula, we see this little network, a whole bunch of tiny branches of the MCA buried in the lateral sulcus. So this color-coded schematic shows the portions of cerebral cortex supplied by the superficial branches of each of the major cerebral arteries. And you can see that in lateral, medial, and inferior view of the brain. So the superficial portions of the circulation supply specific portions of cortex as well as some underlying white matter. So in addition to the superficial branches of the major cerebral arteries that supply the cortex and the underlying white matter, we have deep or perforating branches that supply the internal capsule and the deep brain nuclei. Now, this blood supply occurs in a sort of predictable pattern, but there's certainly variability across individuals. Here you can see the basal ganglia or basal nuclei in three colors corresponding to the primary blood supply for each region, as well as the thalamus, which is mostly in red. And it's mostly in red because the thalamus is mostly supplied by the posterior cerebral artery. And the distribution of the ACA and MCA is pretty sort of predictable here. For example, if I trace the head of the caudate, the anterior portion, as you might guess, is supplied by branches of the anterior cerebral artery in most people. Now, the contribution to blood supply within the sort of deep portions of the corona radiata and the internal capsule is similarly predictable. However, I will say that the contribution of the middle cerebral artery is variable and often outsized. So the MCA often makes a fairly big contribution to blood supply to the internal capsule. Now, if we look in sections, we can see that together, the contributions of the superficial or cortical branches and the deep or perforating branches make to supplying the whole cerebral hemisphere. And so there's schematics like this that just show you, for example, the superior and inferior divisions of the MCA supply the light yellow shaded region here, while the deep branches of the MCA supply this dark shaded region. And this is the similar thing in this time in horizontal view. And I'll just show you that the PCA is supplying this portion here of cortex. That's its superficial or cortical branches of the PCA, while the deep or perforating branches, try stippling, are supplying the thalamus. So now let's talk about the mechanisms of stroke and some common terminology used to describe different types of stroke. So let's start with some terminology. Strokes have sort of two major categories: ischemic stroke and hemorrhagic stroke. In ischemic stroke, blood flow is obstructed to a portion of the brain by something blocking a vessel. So it can be a clot or a plaque, and it's essentially hypoxia of a portion of the brain without bleeding. And that is the majority of clinical strokes. So about 85% of strokes are ischemic in nature. The other type of stroke is hemorrhagic stroke. And in hemorrhagic stroke, a blood vessel ruptures and blood leaks into the surrounding tissue. So the blood isn't getting where it needs to go, ultimately still causing ischemia because it's leaking out of a structural failure in the vessel. And that's the minority of strokes, call it about 15%. Now, infarction is tissue death due to inadequate blood supply. By whatever mechanism. So both of those mechanisms can cause infarction. And infarction is actually a pathological term. So you see an infarct on a pathological slice of the brain or a virtual digital slice on imaging. And infarct has a really interesting origin. It's infarctus in Latin, to mean stuffed into or crammed, and refers to something stuffed into a vessel. Now, in terms of the clinical problem of stroke, a really important thing about the brain is how exquisitely sensitive it is to hypoxia. And so the phrase time is brain emphasizes that human nervous tissue is rapidly and irretrievably lost forever as any stroke persists. And so here we sort of have the time of ischemia, and they break it down to neurons lost, synapses lost, etc. This is an old study, but it's interesting. And the average stroke, the estimate, so that 1.2 billion neurons are lost, and that about 36 years of life are potentially lost. So huge accelerated aging as the result of an average stroke, even if it's survived. Now, ischemic strokes can be treated by TPA, tissue plasminogen activator, a declotting agent. However, it's very difficult to get someone TPA within what's called the treatment window. So the treatment window I have on the slide, 4.5 hours. I've also heard it as 3 hours. So somewhere in that zone is the treatment window for getting someone with an ischemic stroke caused by a blood clot, TPA by IV injection. And the reason there's a treatment window is that prior to that time, the benefits of TPA outweigh the risks by popular consensus. Now, within that time, it involves getting someone to a stroke center where TPA is available, might be in some emergency departments, not all, and also doing imaging to rule out hemorrhagic stroke. Because of course, even though hemorrhagic strokes are the minority of strokes, you don't want to administer an anticoagulant to someone who's actively bleeding. And so it's notoriously difficult. So often this is sort of an acceptable guideline. I've also heard 60 minutes door to needle. So once you get someone into the emergency department, that's a goal. And there's been efforts, such as this study published in 19, to extend that window. Now, this is paper extended, said it was safe. That's the safety window. Whether or not it's effective is still unknown. So these are sort of the most common guideline ranges. But this is why this is why it's so important to get someone who's having any stroke symptoms to the hospital, right? It's a medical emergency. Now, some other terms you might hear to describe ischemic stroke is an embolic stroke, or an embolic infarct, and a thrombotic infarct. So an embolic stroke is caused by an embolus, which is usually a blood clot, but it can be other things, that's formed in one place and then shoots through the bloodstream to suddenly lodge and block a blood vessel in the brain. In contrast, sort of just a pathological contrast or an etiological contrast, is a thrombotic infarct. And that's a blood clot that forms locally on the vessel wall, usually at the site of an underlying atherosclerotic plaque, and ultimately causes the vessel to occlude. So just remote versus local pathological mechanisms. Under the hemorrhagic stroke category, you might hear something called secondary hemorrhagic conversion. This is when a blood vessel ruptures proximal to an occlusion. So the situation starts out with an ischemic stroke, the vessel's blocked, and pressure builds up proximal to it, causing a secondary hemorrhagic conversion. Now, perhaps just due to its huge territory and the number of branches in its circulation, the middle cerebral artery is the most common artery affected by stroke. So a big retrospective imaging study conducted in the US relatively recently found that about 63%, 62.3, of the strokes that were presented clinically were in middle cerebral artery territory. And the rest of them, you can see the breakdown compared to MCA strokes. Both ACA and PCA strokes are relatively rare. Now, when we talk about infarcts, or the pathological territory caused by ischemia, we see large vessel infarcts and small vessel infarcts. So large vessel infarcts involve the major blood vessels on the surfaces of the brain, so the cerebral arteries or their superficial branches. And here we can see a left MCA inferior division infarct. And on this CT, which probably wasn't taken immediately acutely after stroke, it appears hypodense. Now, small vessel infarcts involve the small penetrating vessels that supply deep structures. And these are sometimes called lacunar infarcts, after the Latin lacuna, which is a small lake, because they look like little isolated ischemic territories or little pits in the brain. Here, another CT, we can see a left internal capsule infarct and a little portion of the internal capsule, actually quite a large portion of the internal capsule, is hypodense on CT. Now, just as a reminder, the corona radiata funnels information from a whole broad swath of cortex into a very small region in the deep brain. So that's the internal capsule. So here we've got the precentral gyrus. So this is motor information from the whole precentral gyrus being compressed down to dive between the deep nuclei of the brain via the pathway, which is the internal capsule. And so we've got the parts of the internal capsules here. This is the anterior limb of the internal capsule, the posterior limb of the internal capsule, and this little bend in the middle, the bendy portion, is the genu of the internal capsule. So that is the horizontal capsule, the internal capsule in a horizontal section. And a stroke in the posterior limb of the internal capsule produces what's called a pure motor stroke, a classical lacunar syndrome. So we'll talk more about that as the course proceeds, but question for you to think about right now is how would you distinguish between a lateral lenticulostriate stroke causing ischemia in the posterior limb of the internal capsule only and a cortical stroke based solely on clinical presentation without using imaging? This is a little video. It's this YouTuber, or probably another professor, talks about the anatomy of the internal capsule and has a lovely British accent, so highly recommend. So now let's talk about functional neuroanatomy and use it to predict the deficits associated with vascular accidents in different locations. And this is really one of the most important clinical ramifications of functional neuroanatomy. What happens when blood supply is transiently or permanently disrupted? Now, this diagram illustrates some of the biggest functional bits of cortex that we use to talk about deficits after stroke. And so we have Broca's area, the expressive speech region here, or center, Wernicke's area, the receptive speech center, and of course the primary motor and primary somatosensory cortices, all visible in the lateral view of the cortex. In the medial view, we have the paracentral lobule, which contains both motor and somatosensory representation of the lower extremities. We also have the primary visual cortex, which is here in the occipital lobe, straddling the calcarine sulcus, or calcarine fissure. And finally, we have the optic radiations, which are also included here because they travel fairly superficially beneath the cortex from the thalamus to the primary occipital cortex. So those are some of the major functional regions that we use to think about the clinical outcome of ischemia. Now, the anterior cerebral artery, we'll start with that. It projects anteromedially over the cortex, and its vascular territory is shown here in purple. So here are some of the named major branches, and fortunately the names make sense. They don't always in science, but here they're helping us. So they supply predictable regions of cortex. So the pericallosal branch, as you might guess, travels adjacent to the corpus callosum. And the callosal marginal branch travels slightly superiorly to it, supplying things like the paracentral lobule of interest. The frontal orbital and, frontal polar and medial orbital frontal branches supply regions of the frontal lobe, and so on. So some names that give us some functional clues as to what the cortical territory of these arteries is. Now, when we think about an ACA infarct, or any infarct for that matter, you want to think about the clinical deficits that are typical for an infarct of that circulation, and what region of cortex is ischemic to produce these deficits. So if I start here with the left ACA, for example, I could say that, well, okay, the left ACA is occluded. I know that the most obvious thing I've lost blood flow to, in my mind right away, is the paracentral lobule, right? This critical bit of cortex right here. So that paracentral lobule. And so I'm thinking about lower extremity, which is hard to write, contralateral, motor, and sensory loss. And that would be the first thing that would come to my mind. And right ACA, of course, just the opposite scenario. Now, we've said that the MCA supplies most of the lateral cerebral cortex and also many of the deeper brain structures. Now, as for other arteries, the outcome of MCA stroke varies dramatically depending on where it occurs in the MCA circulation. And we really break this down for the middle cerebral artery because the deficits are quite different and sort of clinically apparent and interesting in terms of functional neuroanatomy. So the segments of MCA from the point where it arises from the internal carotid to its most distal branches are numbered. So the most proximal segment of the MCA is its horizontal segment, or M1. And here's the point at which it arises from the internal carotid. And here is the M1 segment. So this is also called the stem of the middle cerebral artery. If you can read my writing, that's a stem. And an M1 or stem stroke affects a huge swath of ipsilateral cortex, as well as deep brain nuclei and white matter. So this is a really massive stroke. Now, the lateral lenticulostriate arteries, here they are, arise from the M1 segment and supply the deep brain structures. And so some of them are listed there, but if you could imagine, you can have a really selective loss if you have an occlusion of a single lenticulostriate artery. However, because they supply deep brain nuclei and or the internal capsule, the single focal bit of ischemia, which would result in a lacunar infarct, could have potentially really dramatic consequences. Now, in terms of anatomy, we do name these vessels that are buried within the operculum, deep to the lateral sulcus. That's the Sylvian segment of the artery, or M2. Clinically, this isn't super useful. So deficits kind of depend specifically on whether it's the superior or inferior division of the MCA is affected. And finally, we have the cortical, or M3 segments. And so this is the superior division, obviously spreading superiorly, and the inferior division, traveling inferior to the lateral sulcus. That's the dividing point. And the superior and inferior divisions of the MCA are associated with very specific stroke syndromes. So, using the same approach, I'll challenge you to talk about specifics for each of these permutations. We're interested in what happens if you have superior and inferior division strokes, a stem stroke, so that most proximal stroke in the M1 segment, as well as a stroke in deep territory. And you want to be able to do that for the left and right MCA. So really breaking that down, answering these two questions. What clinical deficits are typical, and what region of brain is ischemic to produce those deficits? Now, this table summarizes some of the common lacunar syndromes. And here, syndrome just means the typical clinical presentation of a stroke. Left ACA stroke typically results in left ACA syndrome. You can see what's really interesting is this syndrome, pure motor hemiparesis or hemiparesis with dysarthria, can result from a stroke in multiple locations. And so that's an important feature of this slide. You can also differentiate between a pure motor stroke and a pure sensory stroke and compare that to the locations where a sensory motor stroke might result. Now, we've already seen that the posterior cerebral arteries spread posteromedially over the cortex, and their territory is shown here in green. And the most crucial sort of structure that's supplied diagnostically, straddling the calcarine sulcus, is the primary visual cortex. And so that is the visual deficit is sort of the most classical deficit associated with ACA infarct.